Thank you for the introduction and thank you for having me here today. My name is Liz Roberts and I am a senior research consultant with the advisory board. I'm based here in London, despite my accent, and I lead some of our research on population health management, on strategy, and a lot of the things that you have been discussing today. I, along with my colleagues, have also been fortunate to speak with some of you about the work that you've done through the program and get a little bit more information about the interventions that you've chosen and how you'll be taking those forward. We were asked kindly to join today to talk a little bit about our work on patient management and then more specifically on identifying and supporting rising risk patients. So hopefully some of this will be familiar to you and then hopefully we can move some of this forward as well. One thing, Adrian did mention that you do have access to the advisory board. So if you have any questions about this continues until August. You can talk to myself or my colleague Kieran, who's all the way in the back, and he can answer any questions that you might have. So I will go ahead and get started. Obviously, population health management, as you well know, is a well-entrenched global trend at this point, something that a lot of systems are working on, and that means that there's a lot of information about different things that you can do to support these patients, to target different cohorts of patients, and make sure that you are actually taking steps to change the eventual outcome of how we provide and deliver care. Show of hands, it's after lunch, so I'm sure hopefully you're not too tired, but how many of you have seen this pyramid or something like it? Okay, that's really encouraging. I was going to be concerned if the answer was no one. So we talk about this pyramid quite a bit in our population health research, and I think there's a really good reason for that. This is very, very representative of the overall population cohort, really around the world, that you have a much smaller group of patients who sit in the very top of the pyramid and are high risk, require a lot of care, and oftentimes quite acute intervention. And then hopefully there is a large group at the bottom that is relatively healthy, comes to see their GP for their annual checkup, we hope, and otherwise can be supported in the community without necessarily health interventions. But the group that we want to talk about today is really this group in the middle. So we've termed them the rising risk patients, and I'll get into that a little bit more. But this is a group that I think you all have been talking about in some sense or another. So they're not the sickest. They might have a couple of comorbidities, but they're at risk of needing more care. They're at risk of moving up into that higher group. So I'll talk a little bit about them. Like I said, really common characteristics of these patients who are at the very top. And oftentimes these patients are polychronic, they're very expensive, and they tend to get a lot of focus for that reason. So a lot of people will say, we know who these patients are, we know that we can target interventions at them, and so it makes sense to do a lot of work to support these patients and improve their outcomes. But the reality is that these patients who sit at the very top of this pyramid are likely never, ever going to move back down. So they're not going to go back down to being rising risk patients or even low risk patients. They're in that pyramid, and so the best thing that you can do is support them, make sure they have good care, but at a certain point there are diminishing returns on making further interventions to change the way you provide care for them. And so that's why we say that you should probably focus on this middle group of rising risk patients. They're a relatively large group, and also it's pretty easy to miss them. I think some of the data sets that you've laid out today and some of the things that you've said you found in your in the course of this program have really borne that out, that it's really easy to say, you know what, we think we know who these patients are, we think that frail patients are probably at risk of this, we think we have a good concept of who's coming into our GP's offices, who we might not necessarily know specifically what their outcomes are, but we think that we have this group on lock. But it's pretty easy to miss who the people specifically are. The symptoms are easily ignorable. You might not necessarily catch it in routine visits. And then, like many of you have noted, there are ongoing psychosocial risk factors that might not get picked up in a typical physical screening. And I think this just lays out something that hopefully, again, is familiar to all of you. This is very, very easy for patients in this group to quickly become in the high acuity group. A medical reconciliation issue, a patient being, suffering a fall and then being unattended at home because they suffer from social isolation. All of those things can lead to this patient very quickly moving up into the highest risk category. And in fact, we see that, I'm going to jump ahead a little bit, 1 in 5 patients who are in this group will move up into the highest risk group every year. So it's in all of our interests to identify those patients and take forward steps to improve the way that we're monitoring them. Within this group, I just wanted to point out there's a couple of opportunities for inflection, but then also importantly, an opportunity to recognize where you're probably not going to see any inflection, and it's appropriate to manage those patients with existing interventions, care management, or end-of-life care. Yep. Oh, sorry. That might be very advisory board specific. There's an opportunity to change the way that you're managing their care and prevent further exacerbation of their condition. So, sort of bending that curve a little bit. So you're reducing the incidence of patients moving up. So this just calls out that 1 in 5 number, pretty commonly reported, but 1 in 5 of these patients will move forward. And so I want to think a little bit about what you can do moving forward to make sure that you're identifying these patients and then targeting interventions that can support them. I think from what I heard this morning, a lot of these things will hopefully be somewhat familiar, but I want to push you to think a little bit beyond the data sets that you have and the information that you already have about where you would capture and find these patients. So we talk about 3 opportunities for managing your rising risk patients. The first is identifying them. I think you're all in a great position to do that. The second is making sure that you're using your existing resources to their maximum effect. So what are the areas that you can be expanding your partnerships with community, thinking about different types of partnerships? How can you be bringing different people into the communication? And so for me, the lesson that I will take away is that you are all in a position where hopefully very soon we will be turning to you to learn about what you've done to take to other people around the world as an example of how you can manage these patients. And finally, again, I think the lesson I heard this morning is that primary care is necessary and, in fact, a key motivating factor of this. We find that as well. And so there is a certain aspect of this that's about ensuring that your primary care providers have the resources and the support to take forward the ongoing management of these patients. This will hopefully look familiar. You will have all of these presentations, so I will skip forward as I'm aware that I only have 20 minutes. And what I actually want to talk about, like I said earlier, is that there are many opportunities for identify rising risk patients, but also many opportunities for missing rising risk patients. So a lot of the data that you've talked about today notes when you have found patients who are coming into GPs too often, patients who you might know from some social care interventions, but less often it's about the patients who are unknown at their GP providers or mainly only come in once or twice, and so it's really easy to miss an exacerbation of symptoms. I think it was the Chorley example of the bins and needing and identifying those patients who are getting bin support is an excellent example of this, that those patients, you might not necessarily catch them in the GP, but if you can think about different ways of identifying them, then you can actually find new patients and new cohorts at which to target interventions. So I want to talk about this specific intervention. I'm from Washington, D.C., where this came from, and I think there's a lot of similarities. We have incredible inequality. There's a large group of patients who might not be well served by the existing health infrastructure. And what they found is the African American population in Washington, D.C. was at increased incidence risk for cardiovascular disease that was poorly managed, often because they didn't have access to healthcare and they weren't going in to see their GPs. And so this led to a situation where you weren't finding this incident and you weren't treating these patients until they ended up in the emergency department. So what MedStar Health, which is a health group in Washington, D.C., did is they looked at where are these patients most frequently interacting with anything social, because the incidence or the amount of time that anyone, even a healthy person or an incredibly sick person, spends with a healthcare professional each year, relatively low. But in some communities, there might be places, be it your mosque, be it a church, or for the African American community in Washington, D.C., their barbershop, where you spend a lot of time and you have strong community partnerships and there's an opportunity to find and make changes to their care. So MedStar worked with local barbers in Washington, D.C. to essentially train them about how to identify and educate patients on cardiovascular risk factors and get them connected into appropriate care. Relatively simple. They gave them some blood pressure cuffs. They taught them how to talk to patients about what resources were available. And it's been hugely impactful. 19% of patrons who are seen in barbershops that have this training are identified as having uncontrolled blood pressure and are then referred to follow-up. Doesn't seem like a huge number, but that's actually very impactful for this community and has led to significantly improved outcomes. I want to get you guys talking a little bit. Post-lunch slump is real. So is there anything that you're already doing that you think, you know what, we could do something like this? I know that there's been a lot of talk about engaging community partners. Are you already thinking about this? What are opportunities for doing more of this? Yeah, and I think that that's actually borne out in the things that I hear in my conversations and also in the research that we've done. Data is an incredibly powerful tool, and I'm not at all trying to say that data doesn't matter. It absolutely matters. It gives you insight that you wouldn't have had before. But I think that there's something incredibly powerful in marrying the things you already know. Who are the populations that are suffering in your community? Who are the people that you don't have a chance to speak to on a regular basis? Where are areas where you think, you know what, I actually on a gut level know that this is a problem? Can you do different things to help uncover that and then maybe marry some of that data into it? Or say, actually, we need more data to actually prove that this is a problem. And so I've heard a lot of that happening throughout the day. I think there's a lot of instances of people saying, we actually know where the communities who need more support are. We actually know where there are opportunities for us to work better or closer with our colleagues. And I hope that this is an example of how you can do that. I'll just go forward a little bit further. This is an example from Jersey, who decided to use their postal workers in a different way. So talk about a community resource, people who are going around and walking to every house on a daily basis, and think about the powerful impact that could have on your ability to uncover incredibly unknown need. So this actually came from the postal workers themselves in Jersey. There was a competition that asked them to say, what else could we be doing? Is there more opportunity for us to work differently? And so they introduced what's called the call and check program. And essentially they gave postal workers a little bit of training about how to spot incidences of risk or patients who might need a little bit more support, be that health support or community support. And when they go around to deliver the mail, they'll knock on the houses that have been identified as potentially problematic and just do a quick questionnaire. Does the patient seem disturbed? Do they need support? Are they confused? Have they not picked up their mail lately? Is that a cause that maybe I should call someone and see and have them check in on this? This only costs about £10 per postal worker per day, so it's not an incredible burden, and it wasn't a huge amount of additional training, but it has allowed them to identify where they can be doing more and just given them an additional data point, even if it doesn't come from a computer or come from an existing database. Any other questions about this? I hope that some of this is familiar for you. I hope that it reinforces that a lot of the work that you're already doing to identify these patients who are at risk of escalation into a more serious category is a powerful and important way of improving the care you deliver. Any other questions? This is an example of a HealthLink worker identifying patients who might escalate because of a change in their income and then having to be admitted into hospital, losing their secure housing. Absolutely, that's a problem. And I'm happy to speak further about this. So we've done some additional research on some of our patient activation measures, and one of the things that does come out of that is that those non-clinical factors are incredibly important. So certainly we profiled some organizations, Voluntary Action Rotherham, which is actually embedded in GPs to help connect some of the social services that are available for patients, flagging certain things like income inequality or insufficient income, housing insecurity, those things that actually have a much bigger impact on patients than I think as a clinical community we're sometimes quick to recognize. Thank you.